It's lovely to see you all. My name is Peter Leedman. I'm the CEO of the Harry Perkins Institute, and it's a very great pleasure to welcome you all to our first Q&A of the year. And before I get going, I'd just like to acknowledge the traditional owners of the land on which we're gathering tonight, which are the Rachael people of the Noongar Nation, and in particular to recognise First Nations people as Australia's first healers and scientists. We often forget that. Their collaborative wisdom, culture and traditions have nurtured this land, our land, and its people for tens of thousands of years, and they inspire our mission to improve community health and keep families together for longer. And we pay our deepest respects to their elders past and present. Now, tonight we've come together to hear from one of the world's leading genetic researchers, Emeritus Professor Nigel Laing, AO. He is, someone's clapping over there, you're absolutely right. Because Nigel is, and we're going to hear from him and a number of other wonderful people on our esteemed panel, and they'll be introduced by Miriam Borthwick in a moment. Nigel heads our preventive genetics group at the Perkins, and he has literally dedicated his life, as some of you will know, to finding answers for families affected by rare genetic diseases. And I'll mention it now. Tomorrow is Rare Genetic Diseases Day, and it's worth everyone knowing that in the audience, and we'll come back to that a little later. And we're celebrating a really important milestone made here by Nigel and his colleagues, and the project's called Mackenzie's Mission. You'll hear a lot more about that in the next 45 minutes or so, but just very briefly, Mackenzie's Mission was inspired by a beautiful little girl, Mackenzie Casella. And Mackenzie was born with an unusual and rare genetic disease called spinal muscular atrophy, or SMA. And unfortunately, Mackenzie died at just 7 months old. And her parents, with that terrible news, went on the fight for recognition of the need for more research about SMA and rare genetic disorders, and especially the need for a national screening process to help families make those really difficult decisions and understand their genetic risk for having a child that might have a problem. So Mackenzie's parents, Rachael and Jonathan Casella, were instrumental in getting $20 million. $20 million, a lot of money, some years ago. And their commitment was from Greg Hunt, who was the previous Minister for Health. So there was a lot of lobbying, and Nigel was front and centre in that with Rachael and Jonathan. And the project, of course, was named to honour little Mackenzie. And it was a national research project, and it got going, and Nigel will probably tell you about this, around the time of the pandemic, back in late 2019, early 2020. And interestingly enough, it was a project between three key investigators, two on the East Coast and Nigel here on the West Coast, and together with Path West and a lot of collaboration, they were able to start it and really get it going from here. And I think all credit to Nigel and his team with Path West for being able to do the bulk of the screening in Western Australia. And again, just reminding us all that we do punch above our weight here in Western Australia for science. Last November, Nigel and the colleagues involved in this wonderful study published a paper in the New England Journal of Medicine, which is the most prestigious journal in medicine that we can have, and Nigel was the senior, or i.e. the person who orchestrated the whole thing, being the senior author. And that really is an amazing honour, and we might give you a round of applause now, Nigel, just to recognise you. And most importantly, and in medicine, it's really hard to do research that has a real impact, a direct impact. But as a consequence of Mackenzie's mission, since November 2023, carrier screening for 3 genetic disorders, not 300 or 30, unfortunately, but hopefully that we'll get to that, but 3, SMA, cystic fibrosis and Fragile X. So they're all now available and covered by Medicare, which is a fantastic outcome of clinical research. There's obviously a lot more to go, a lot more to do in this area, and our panel are going to discuss this. And I think that's the core of tonight. We're going to hear from a panel of experts about this whole issue and how the government needs to be lobbied, and we all need to continue to lobby them. So before I give any more away, because there's lots for you to hear tonight, I'm going to hand over to Miriam Borthwick. And Miriam used to work with us at the Perkins. She's an incredibly talented media person, used to be running the 7:30 report, and she loves Q&As, and we love having Miriam here running them. So let's look forward to a wonderful night, and thank you very much, Miriam.
Thank you so much, Peter. Now, how's that volume? Good? Noise everywhere. Well, what an opportunity we have this evening to hear from Emeritus Professor Nigel Laing, AO, who, as Peter said, has dedicated his life to hunting for rare disease genes and genetic mutations. Next to Nigel, we have Associate Professor Lucy Gilkes, who's a GP and also an academic who is involved in Mackenzie's mission. Alongside Lucy is Sam Edwards, a genetic counsellor who also works here at the Harry Perkins Institute of Medical Research. And next to me is Ruth Stephen, who has very generously given of her time and of her family story. Ruth and her husband lost a baby also to SMA, spinal muscular atrophy, in 2006. Spencer was 7 months old. So I thank you very much for sharing your story tonight, Ruth. Nigel, let's start at the beginning. What are rare disease genes? How common are they?
Whoa. Before we start, can I say something sort of... Every Thursday, my wife and I, Sue, we look after, or help look after our granddaughters. I've spent the entire day talking to a 2-year-old. So it's quite a change to be able to talk to a room full of adults. But if I revert to being grandpa, just raise your hand. Genetic diseases. One of the things about genetic diseases that I like is that they're conceptually simple. If someone has a genetic disease, it means that somewhere in their genetic makeup there is a change which shouldn't be there. And that then means you know that somewhere in that person's genome there's the variant that's causing the disease. And yes, we've devoted our lives to trying to find those causes. We have over 20,000 genes. I've seen estimates that there are over 10,000 different genetic diseases, and I've seen people write that about 2% or 1 in 50 people in the population have a genetic disease.
And Ruth, that was your family's story in 2006. Can you tell us a little bit about Spencer's story?
Spencer was born in March 2006. He was born with and presented with all the normal signs of a healthy baby. I did suspect something was different about him when he was born, but was dismissed by all the midwives and doctors that, you know, it was all just a worrying mother. But then his symptoms started to progressively increase. We noticed that he wasn't swallowing his milk properly and wasn't breastfeeding properly. He didn't develop head control, and that was one of the things that the child health nurse was most concerned about. So I would try and put him on his stomach to put his head up, but then because he couldn't breathe, he would get distressed, and that became a cycle of us fighting with each other over trying to get him head control. But then he started to lose use of his legs as well. And so by about 9 weeks, we knew that something was desperately wrong. And by the time he was 12 to 13 weeks old, we were given the diagnosis of SMA.
And there wasn't any genetic screening at that time in 2006, was there?
There was no screening, no.
And no treatment for spinal muscular atrophy.
Right.
We will come back to Spencer's story. I just want to move quickly to what we're primarily talking about tonight, which is Mackenzie's mission. And so Sam, you and Nigel were integrally involved in rolling out this national research pilot to see how, at a national scale, pre-pregnancy carrier screening could be carried out. Can you just briefly tell us about how that was established, how you rolled out Mackenzie's mission?
How we rolled it out.
Okay.
Put your hand up then. Yes, I can. So, thanks to Johnny and Rachael Casella's fight and Nigel's hard work, along with Edwin Kirk and Martin Delaticki on the East Coast, we were awarded a $20 million grant to try and get this up and running. And we spent a year, and when I say we, it was a massive team of genetic counsellors, of clinical geneticists, of doctors, of laboratory team members. Who am I forgetting? I'm probably forgetting others, but it was a massive team from all around Australia, and we spent a year basically trying to come up with the best way at the time that we thought we could roll out a national program and trial that. And we did get it off the ground to start with here in WA, in New South Wales and Victoria. As was alluded to by Peter, it was right before COVID that we started, so then we had to try and manage that, which luckily it was set up in a way that it did cope to a degree. And we were able to recruit close to our target of 10,000 couples to test and offer this screening.
Were people quite quick to enrol?
They were. In fact, we were having to, unfortunately, say no to people. So it was one of the aims of the study that we wanted to make sure that we recruited in a way that showed the demographics across Australia and the widespread examples of people across Australia. So people couldn't self-refer or self-register themselves into the study. They had to be invited by a registered healthcare professional, which means our teams had to select various healthcare professionals around Australia.
And how many disease genes were you testing for?
We tested for roughly around 1,300 genes, which covered about 750 conditions.
Nigel, can you explain that for me?
How do you mean, Graham?
Well,
So
I thought it was just 750 disease genes you were testing for.
No. So we tested 1,300 genes, which are associated with 750 diseases, because more than one gene can cause the same disease, right? So that's just how it works.
And how did you decide which diseases you wanted to screen for?
We spent 18 months, this panel of people, clinical geneticists, scientists, ethicists, Rachael was involved, Rachael Casella was involved, deciding which recessive genetic disease we should analyse for. In the workshops that we had held previously, it was decided that the conditions that we would screen for would be severe diseases affecting early in childhood, plus ones for which there was a treatment, so that are involved in newborn screening programs as well. So it was this huge effort over 18 months to decide which genes we should screen for, and came up with 1,300.
And how long did Mackenzie's mission run for?
So we aim to start really recruiting in March 2020. Something happened in March 2020, which was the COVID epidemic. But brilliantly, I don't think it was chance, I think it was brilliance on our part. We organised Mackenzie's missions so that couples could enrol through a website and do all the consent through a website. And once they completed the consent, then cheek swabs were posted to them at their home address. And they could do take the cheek swabs and stuff, and then those were posted back to the laboratory. So we had basically COVID-proofed the project. We became totally reliant on Australia Post, which was interesting in some cases. Because one of the things that Greg Hunt asked us to do was make sure that we could take carrier screening to every nook and cranny and corner of Australia. And so we did that. And this Australian Bureau of Statistics has numbers of what proportion of the population are in remote regional areas, metropolitan and so on. And we hit those proportions almost exactly. We took carrier screening to every corner of Australia, including using the Royal Flying Doctor Service in WA.
And so here in the laboratory here and Perth West, wasn't it?
Yes, so all the laboratory work was done in 3 NATA accredited laboratories, one in Sydney, one in Melbourne, and Perth West next door here.
But here we were receiving saliva cheek swabs from around the country or just from WA?
So the Perth West lab, the original plan was that we would deal with Western Australia, South Australia and Tasmania. But then COVID really badly hit the labs in New South Wales and Victoria. And so Queensland, which was originally supposed to be dealt with by Victoria, came to us instead. And in the end, originally the plan was that New South Wales and Melbourne would do 4,000 couples each, and we'd do 2,000 in Perth West. And it ended up with the Perth West lab doing more couples than the other 2 labs.
And as a result of the numbers that you recruited, and Lucy was part of that, and I was just going to come to you in a second, but of the 750 disease genes which were tested for, what chance was it that you found that a couple could have one of these severe disease genes?
So we screened 9,107 couples. And we showed basically that 1 in 50 of those couples had a high chance of having a child. That's the 1 in 4 chance of a recessive disease. I was supposed to look at the audience, not at Mary. Forgot about that. 1 in 50 of the couples had the high chance of having a child with one of these severe recessive diseases.
So 2% chance?
2%. 2% of couples.
Yes.
It's interesting, I gave a talk at Cambridge University about this a couple of years ago, and one of the scientists in the audience came up to me after I'd spoken and said, 2% isn't very many. And I said, that's 1 in 50 couples. And they went, ooh, that's quite a lot really, isn't it?
Yeah. And Lucy, you were, as a GP, involved in recruiting couples for Mackenzie's mission. During Mackenzie's mission, let's just stay in that time frame, what was the experience like for you as a GP? So you've got a young couple, they come to you, they're planning to have a family, it's in the time of Mackenzie's mission. How well supported were GPs in that time?
It was a very beautiful, I'm going to say, well-designed study in that in general practice it's very hard to find time in the consultation to do something else, particularly to recruit people to a study. But this was done really, really well because all it needed me to do was to explain it to my patients and to give them the form that I was given, which was I think also the request form from memory, and it pointed them to this website, which I was aware as being part of the study design team, some of it, had a really good decision support tool in it. So I knew that I would talk to my patients about the option for testing as a couple for genetic diseases, and I was able to be happy that they were getting enough information to make the decision about being involved in the study, because there was a lot of information available to them through the website, and there was counselling available linked to the study.
Always provided the counselling?
If needed, yeah, if needed, if they were positive, yeah, if they came back as a couple and they were positive. But also I think there was available if they wanted to ask more questions about being involved in the study.
Yep.
Yeah.
Yeah. And Nigel, you met the Casellas, didn't you?
Yes.
They sound remarkable.
They are astonishing people. I've only met them for the first time when we were in Canberra for budget night in 2018, and Greg Hunt invited us to go and visit him in his office and then be in the lockdown while they announced the budget. And we didn't know about the 20 million. We didn't know that it was going to be 20 million until we met him. And it was just an astonishing day, and they were remarkable people. And if anyone wants to read about the advocacy that they did and what they put themselves through to make this happen, Rachael has written a book called Mackenzie's Mission about everything that they did. And if you can read through that book without crying your eyes out, you're a stronger person than me.
And Ruth, how does it feel to know that it was a couple who also had a baby with SMA, whose lobbying has led to this national research project?
I feel a sense of pride in one way, I suppose. Not that I know the family or had any connection with them, but certainly a sense of pride. Yeah.
Quite a legacy, isn't it?
Yeah.
Yeah.
Yeah, it is.
But Mackenzie's mission has finished. It is no longer. There's results from it, there's information that's been gleaned from it. It will inform future things, but it is no longer. So, Nigel, one of the profound outcomes was 3 of the most severe disease genes is now Medicare rebatable, if that's a word. You can get a Medicare rebate for it. Do we have any stats so far on how many or what the take-up is of couples now of take up the opportunity for the 3 disease genes via Medicare?
Yes, we do. That's one of the wonderful things about Medicare rebates. There's a website that you can look at and you can dial up any Medicare rebate that you want to look at, and it tells you how many times each month that rebate has been used. So it started on the 1st of November 2023, and by the middle of last year, the peak so far for 1 month was the equivalent of 154,000 couples accessing the 3 disease carrier screening. We have only around 300,000 births a year in Australia. So you can sort of perhaps say that means that half of the couples in Australia in a year who are thinking of having a child are now accessing rebated 3 disease screening. And what that says to me is there is a huge appetite in Australia. Young couples who are having children want access to screening.
How effective is, just for those 3, the 3 that are Medicare rebatable, how effective is the screening? Are there false negatives, false positives?
Can I say 2 things? Right. So what we found from Mackenzie's mission is that if you do the big panel of genes that we did, you detect 5 times as many high chance couples as doing the 3 common ones. So doing what we did is 5 times more effective in a way than just screening for the 3. There are always false positives and false negatives. There are fewer false positives and false negatives with cystic fibrosis, SMA and Fragile X because they've been known for longer and they're more common. So the variants in CF are well known. Same for the variants in spinal muscular atrophy and Fragile X, although there are some issues with spinal muscular atrophy because its genetics is a bit weird. So you can miss some high chance couples. So you can get false negatives.
Do you put a figure on the false negatives?
You can for SMA, and I can't remember what it is, but it's a small fraction, something like 1% or 2%.
Right. And so Lucy, now as a GP in the world post Mackenzie's mission, let's say a couple comes to you, they're planning to have a baby. What's the experience right now for you as a GP?
This adds to the content, I guess, of the visit when someone comes in preconception planning, because there's a lot of things you talk to couples about before when they're planning a family, or indeed you can also offer the testing in early pregnancy too. And it's something that GPs are learning to incorporate into their counselling to a couple that are intending to fall pregnant. Not only the 3 disease screening, you can, in the private labs, offer an expanded screening as well, but it's very expensive. Can be, I think, $1,000 we said, is that right? Yeah. So it is available as well, and I think the price is going down. So I try and have a conversation about that too, because as Nigel said, it's 5 times better. So there's a lot extra added to that consultation, but it's definitely worth it because it's important, and couples are very receptive to this discussion.
And you find
generally.
couples know about the 3 disease gene screening?
I think a lot of the time, yes, it's definitely driven by people hearing about it from their friends or family, or someone else has talked about it and they've come in. A bit like when we started doing the NIPT, the testing for the pregnancies, for chromosomal abnormalities. Often people would be coming in asking for it quite early on. So yeah, it's driven by people asking about it, but also it's something that you introduce as a routine now. It's a recommendation now is for GPs to talk to patients about this in preconception planning and also in early pregnancy.
Actually, you mentioned the chromosomal disease. How often do couples not understand that, of course, something like Down syndrome isn't tested by genetic screening because it's a chromosomal disease, not a genetic? I mean, how much sort of misinformation exists, and how much work do you have to do to give, genetics 101 in the?
I mean, it's a part of being a GP. It's a really important part of what we do is patient education. And checking whether people understand, giving them access to resources to learn about it. Yeah, I think it's unreasonable to expect people to know a lot about genetics generally. So yeah, there's discussions about it, but I think usually people will understand it, and there's good written information to accompany the tests too. So yeah.
So let's just stick with the 3 disease gene screening. Do you just send the woman off first individually, or do you do both together?
I think for the Medicare rebated one, it is just the woman initially, yeah, for the 3 disease one. Yes.
Is she likely to come up with a number of things, or?
So the 3 disease one, Nigel's going to have, and Sam will have to help with the stats. The problem is, my understanding is the very expanded carrier screening, if you do enough tests and you just test the individual, everybody will come up with 1 or 2 tests that are positive because the numbers.
So that's if you're doing a broader
expanded
screening, not
testing.
just the 3.
Yeah, 3 it's unlikely. Yeah.
Okay, all right. And so, actually, Sam, walk us through this. So, so couples come to you as a genetic counsellor. How do you, first of all, describe to them or help them make decisions? What do you first need to provide them in information?
As a genetic counsellor, the first thing I would want to do is find out what it is they actually want to get out of the testing. So, for example, some people are information seekers and they want to know anything and everything they might be a carrier for, so individual carrier screening might be good for them. Whereas if it's a couple and they're not really concerned about whether one of them's a carrier for something and the other isn't, but they want to know as a couple what are our chances of having a child with a genetic condition, then couple screening, for example, would be better for them. So it's really every couple or every person that comes for screening has got, I guess, a different perception about what they're entering into and what they want out of it. So it's really important to make sure that we're answering their questions. It's also about the level of risk or reassurance we're potentially giving them by offering them a test. And not every carrier screening test is exactly the same.
No, we need to explain this. So now we're not talking just about the 3 disease screening, we're talking about a couple saying we would like broader screening. So let's just break it down. What might the cost be for that?
Anywhere from, say, about $400 to possibly $1,000, and that could be as a couple or it could be as individuals, depending on what type of testing you want.
So if they're going individual, they'll be paying twice if both of them, okay. And so you've just given a range in price. One assumes that's because there's a range in what the test is.
Correct. So you could be looking at a few hundred genes or conditions, or around about 1,200 genes is the current top line test.
And how do genetic counsellors, how does a couple, how do GPs know which labs offer what, and is it set? Because in Mackenzie's mission it was set 750. So what is there confusion out there?
To put it simply, probably yes. I mean, as genetic counsellors, we are expertly trained in looking at these things. We know what labs are out there. We tend to hear about whether things are changing or not. It's a lot of information even for us as genetic counsellors to keep across, I should say. So I feel for GPs and obstetricians who are more than capable of requesting these tests to try and keep across it. It's a dynamic field and it is changing all the time because our information about genetic conditions is changing, and so is the technology that we're using. So it's a bit of a minefield, but it's an exciting one.
So let's say a couple says, yes, we'd like to go ahead with broader, wider genetic screening other than just the 3. You've explained to them the cost. They send away, they decide what laboratory this is going to go through, how many disease genes are going to be tested for. They give their saliva swabs, and then how long does it take before they might get a report back, and who gets that report?
Sure. So depending on the tests that they've ordered, you could be looking at maybe 2 to 4 weeks or anywhere up to about 6 to 8 weeks. And that can also depend on whether the laboratory's here onshore in Australia or whether it's being sent overseas for the testing to be done. The report will usually come back to the healthcare professional that's ordered it for them. There are some services where it will come back to the patient, but there's usually healthcare providers built into that laboratory system.
What sort of results might they receive?
So if they've gone for an individual carrier screening, they will get a report saying, yes, you are a carrier for A, B, C, and the rest you have not been found to be a carrier for. If it is a couples test, then you will get either a low-risk test or low-risk report, I should say, which means that they haven't found you as a couple to be at risk, both at risk or both carriers for any of the conditions that have been screened for, or you will come back as increased risk or increased chance for one particular condition, possibly more than one, but generally it's one.
So if it comes back low risk, why doesn't that say no risk if they haven't found?
Because we can't test for everything. No test covers every condition out there, and then those that we are screening for, there's always, I guess, a residual risk. So either we don't know everything about the condition or the genes that we're looking at, so we're not capable of detecting a gene change that we don't yet know about, that we don't yet know causes disease. So there's a possibility that we might miss something, but it's usually small.
So if it comes back low risk, the couple should be able to feel comfortable.
Reassured.
If it comes back high risk, what does that mean and what are the next steps?
Sure. So if they're high risk, if it's a recessive condition, it means that they are at, or each pregnancy that they would have would be a 1 in 4 chance or 25% chance of being affected with the condition that they're high risk for. So they have a number of options that they could explore in having a family if they wanted to avoid having a child with that condition. They can either fall pregnant naturally and then choose to test the pregnancy at around anywhere between 12 to 16 weeks, and then based on the result that comes back, decide what they would like to do, continue the pregnancy or not. Or they can go through an IVF procedure and have embryos screened and only implant unaffected embryos as well. There are a few other options, but those are generally the 2 routes that most people will
And
take.
I know this is just a ping-pong session of questions and answers here, but what happens if the couple waiting for the appointment with you fall pregnant?
Fall pregnant, so as I said, they could either choose or naturally fall pregnant, and so we can test in pregnancy.
So you can do the same cheek swab test once pregnant? No. Yes?
Sorry, to test the pregnancy to find out if it's affected?
What I meant was, so you haven't had the screening yet,
Okay.
you've fallen pregnant.
Yes.
How will you know what risks you have then?
Yes, so yes, in early pregnancy you can have the screening. Technically you could have it at any point during the screening, but in order for you to use the information that test is going to give you, it's better to have it earlier on in pregnancy, but best to have it before you fall pregnant.
And final question, do couples make different choices pre-pregnancy and post-pregnancy of what conditions they think that they would be okay with living with?
Yeah. Yes, they can. I mean, I think as a genetic counsellor and over my years, people go through life, and at any stage of their life they could make a different decision. So it could be 1 year to the next they could make a decision. It could be pregnancy versus non-pregnant that could change their decision. So it's a very, it's all about the context that they're in at the time.
Yeah.
The screening or the conditions that we screen for in this test also, they're not all the same, or people won't make the same decision about them. So, for example, things like spinal muscular atrophy and cystic fibrosis have treatments now. Depending on what gene changes you have, someone or a couple might decide that they would like to go forth with a pregnancy and choose to have treatment for the child. There are other conditions that we can screen for and find a couple at high risk that if they had an affected pregnancy, if they put treatment in place very early, as soon as baby was born, they would have a fantastic prognosis because the treatment is very easy. It just depends on the condition, and then there are those that are horribly severe and just would not be nice. So it's a personal decision based on what the condition is and what options are available for that condition.
Complex.
Yeah.
Ruth, you started telling us a little bit about Spencer's journey, and it was about the 9-week mark that was when you actually got a diagnosis?
He was 12 to 13 weeks when we got the diagnosis. It was around 9 weeks that we realised that there was something drastically wrong. But it was a few weeks before we were given a diagnosis.
And can you speak up a little bit?
Sorry.
And yeah, so tell us don't tell us about the moment of that, getting the news. That must have been horrific, but you didn't have any idea this was a possibility, did you?
No, we did not. We'd not heard of SMA and did not know we were carriers, and that was what our son was being affected by. And I had no idea.
Yeah, and his journey from 13 weeks, were you in and out of hospital a lot? Not initially. I think after a couple of weeks after he was diagnosed, we had testing done on his swallowing because he wasn't swallowing properly already, and that resulted in him having a nasogastric tube fitted, and so he was fed through the nasogastric tube for the rest of his life. And then he got RSV when he was about a month later after that, and we spent, I think, 3.5 weeks in hospital with that, and almost lost him a few times in that process, and went home with oxygen and BiPAP machine, and that was sort of the last stages after he had the RSV. Yeah. And he lasted until he was 7 months?
7 months, yeah.
And did you go on and have any more children after Spencer?
Yes, so we had genetic counselling after Spencer and made the decision to do the pre-implantation genetic diagnosis, is that what it's called? Yeah. PGD. And so we went through the IVF process and now have a son who's 16 and he's healthy and and he's not a carrier either. Of all of the eggs that were harvested and then fertilised and tested and got to each stage of the testing, we ended up with 3 embryos that were potentially viable. 2 of them were carriers and 1 was not affected, and that's Archie. So we got lucky on our first attempt at PDD.
Great. Well, I'm really sorry for your loss, and I'm really grateful and the generosity of you sharing Spencer's story. Nigel, the future. The challenges that were involved in setting up the national program, what are some of the big ones that lie ahead before Australia can actually have a Mackenzie's mission style national screening program?
There's really only one challenge, and that's getting Mackenzie's mission style multiple gene, multiple disease carrier screening funded.
But the funding providing things like, I mean, what about the storage, the number of counsellors, the educating for GPs, the website, all of that I'm imagining, which was set up in Mackenzie's mission, is what you would be wanting.
Yeah, so first people have to decide that they're going to make it happen. And then, as you say, there's how many labs do you need to do sequencing at that scale for maybe 150,000 couples a year? Do you build one enormous government sequencing facility somewhere? Do you distribute it amongst different laboratories? From my point of view, our experience with COVID and WA shutting its borders and keeping COVID out, which allowed pathways to continue, I would advocate strongly that there should be distributed laboratories, and one of them should be here in Western Australia, because if we have another pandemic, I expect WA would shut its borders and that lab could continue like we did before. There's also the question of how many genetic counsellors you would need. One of the good things about the couple-based screening that we did in Mackenzie's mission is you need far fewer genetic counsellors than if you're doing carrier screening for individuals. We looked at a subset of the people who were enrolled in Mackenzie's mission as individuals and showed that 93% of them was a carrier for one of the conditions that we screened for. Basically, if you screen for enough recessive conditions, each one of us is a carrier of something. So by doing the couple-based screening, you cut down on the number of counsellors that you need. And I've done back-of-the-envelope calculations about how many genetic counsellors that we would need, and it's not as many as people might think. Story that, I know you don't like that sound, but you know.
You still need us.
Yeah, I mean, genetic counsellors are essential. And how do you store all the data? How do you make it all secure? And so on.
I mean, this has been your life's work.
Part of my life's work, yes.
Yeah. How commonly are new disease genes being found around the world?
Gina, how often are you finding a new disease gene?
A few a year.
The one lab here on the 7th floor.
Okay.
So they keep being found. So I suppose what you're asking is what do you do about the gene list? So the recommendation that MSAC made when it knocked back making our version of screening Medicare rebated test was that there should be a committee like we put together to decide the 1,300 genes we'd screen for. That should periodically reassess what new genes have been identified that also cause severe recessive diseases and which ones you'd add in to the list that you would do. In actual fact, once you get to 1,300 genes, adding in a few more doesn't actually change the workload very much.
Some countries have been doing this for a long time. I'm thinking you used to talk about Israel.
Yes, but they do it differently there.
Let's not worry about the process, but the actual approach. You can worry about the process. But the actual 20 years of doing it, have they fairly much eradicated the disease? Is that possible?
No. There are reasons why you can't eradicate these things. one is that different couples make different decisions. The American College of Obstetricians and Gynecologists said that carrier screening should be made available to everyone. But then people had to use their own personal values to decide whether they were going to use it or not. So not everyone is going to use carrier screening. So there will always be people with these recessive diseases. And the other thing is, we keep mutating. It just happens. So, for example, spinal muscular atrophy, the textbooks will say that the mother and the father are both carriers, but that isn't necessarily the case, because the one sperm or the one egg that gave rise to that child may itself mutate. So you keep getting new cases of spinal muscular atrophy, for example, where one of the parents isn't actually a carrier.
So spontaneous mutation.
Yes. When you know, the way to make that simple is, the calculation is it would take 17 years of non-stop typing to type out the human genome. So every time your cells divide, they have to do the equivalent of 17 years of typing. No biological system can be so perfect that it doesn't make a mistake. So again, the biology textbooks we used to read said, the DNA in every cell in your body is the same. No, it's not. The DNA in every cell in our bodies is different.
The horrible thought of the errors made in typing and what you just described is alarming.
Not all errors are bad. You have to keep that in mind.
Ruth, Spencer's legacy is kept alive. Obviously, your love for him continues in your family's hearts. But you have created a foundation with the lovely title of Team Spencer. Can you just tell us a little bit about what it is that funds?
We have been raising funds since 2007, and currently over $500,000 we've raised, and the funding has been used for PhD scholarship, research in a treatment for SMA, and there's been, I have a list of all sorts of things that we've used the funding for, and my mind is
That's right, you told me large gala balls have been held.
Yes.
Treatment came available in 2019. Let me give you the summary. The nurses, particularly because of the assistance with spinal infusions with the treatment?
Yes, that's right. That's one of my favourite uses for the Team Spencer funding. When a treatment called nusinersen, which is now called Spinraza, became available on the PBS in 2018. I'm looking to Hayley over here from Neuromuscular WA for a nod. It was put on the PBS, so it was funded by the federal government, but the hospital wasn't able to fund a nurse to administer the treatment, and what Neuromuscular WA was able to do with the Team Spencer funding was to fund Jodie Mann, and she was able to then treat the 9 patients that were waiting to be available for the treatment.
Yeah. How many in WA were you ever told how many SMA babies are born in WA each year on average?
I recall Peter Rove, our Spencer's neurologist, saying that there was about 1 in 10,000 births, which meant 1 child every year on average. Right. Yeah. Yeah, sorry, I lost my train of thought there.
No, sorry. Look, I'm sure there'll be questions from the floor. And have we got someone with microphones? Yes. One? Yes, yes. So please just put your hand up so that we can get a microphone to you as quickly as possible. We've got a range of ages in the room, so it might be grandparents who are interested in asking the question as well as young people perhaps planning a family.
My name's Danielle Green. I've unfortunately lost both my children to a rare condition, PPA2, which Gina was actually involved in finding. Thank you, Gina. One of my questions is, when we asked our GP about genetic testing and pre-screening, we were kind of told a lot of misinformation, that it was quite expensive and we actually didn't need it, even though our son had already passed at this stage. So I just was wondering, what are we doing to better educate our GPs in this area with the information that Mackenzie's mission has provided us?
Lucy?
I agree. I think it's a very big part of what needs to be done is for GPs to be educated about the current state of genetics, bearing in mind it's changing very rapidly, as we've heard, and there is quite a long lead time usually between something amazing that's discovered here and what becomes mainstream practice. I'm sorry that you had that experience. There is actually another very large grant that's been awarded to another group. That's exactly that, genetics education for GPs and working out the best way to do it, most effective way to do it. That's underway currently. So I think that people are realising that's a really important part of what needs to happen next in genetics. The College of GPs recommendations for testing that's done in preconception counselling and early pregnancy counselling used to recommend that GPs take a family history to see if there's diseases that run in the family, and that was the main sort of recommended practice until fairly recently, to be honest. But now the recommendation is to talk about genetic carrier screening. So that has happened and it's starting to appear in guidelines and things for GPs. But I agree, it's very, it always seems very slow when you hear the exciting things that are happening and how long it takes to translate to practice that every GP will be doing something.
Can I ask a follow-up to that, actually, if I can jump in? If we do have the experience where we go to our GP and they don't offer that information straight up, what's some good resources that we could go to self-advocate or to bring that conversation up with our GP?
You mean where you can point the GPs to go?
Yeah, or how to prompt that discussion with them.
The Mackenzie's mission website is still available. I've found that very useful, and that links to private labs that are available for expanded carrier screening and gives details of the sort of service that's provided by those labs, which is very, very different between the labs. So it's one of the tricky things about this process, because there's one that I would happily use and others that I've tried before and wasn't quite happy with the service. So it's a tricky area for GPs. I think if you were to go to the Mackenzie's mission website and say to your GP, I'd like to be referred for this testing, you can even download the request forms there and ask your GP to do it. One of the things in GPs that happens is we often are led by what our patients bring to us. So if someone brings something to me and I've never heard of it, then I can learn from what you're bringing to me. So that's quite commonly happens in GP, to be honest. There's not necessarily a coordinated way to get information to every GP. There's no like standard educational modules that we have to do every year. So it is a tricky area, I agree.
Sam, how do couples get to you, get to a genetic counsellor?
Sorry. So quite often, say if they've had the 3 disease screen and have come back as carrier, they and their partner, they will get referred to a genetic counsellor to talk about the result. Otherwise, there are GPs who might not be comfortable that they're across the different options, or might not be comfortable that they're going to best serve their patient, and so they might also refer on to a genetic counsellor. And some fantastic couples just go out there and do the research and come across us themselves as well. But yes, there are genetic counsellors that you can access out there, and not necessarily in the public system. Unfortunately, there might be wait times, or they can only handle those who are definitely high risk, but there are private services for genetic counsellors that can see anybody who wants to walk through the door and ask a question.
Because we're only, just for clarification, and it will be obvious to people who work in genetics, but for the rest of us, we're only testing for recessive disease genes, aren't we?
Yes, recessive and X-linked, just to complicate
Well,
things.
don't complicate it. But why not the dominant?
Why not the dominant? So if you have a dominant genetic condition in your family and you're at risk of passing it on to someone, it's because you yourself have that condition. So more often than not, you would be showing signs, or you would have seen it in another family member and know that you are at risk. The point of carrier screening is about reproductive risk, the hidden genes or gene faults that we don't know about that you might pass on to your children. So there's other testing available for dominant genes.
Off topic or not, a case I was involved with concerned a baby that was born with malignant cofactor deficiency, which I understand is very rare, as we're discussing tonight. The baby was taken in by the mum to Princess Margaret with just sort of vague and confusing symptoms. What would trigger a clinician to screen a baby for a genetic problem when the presentation features are sort of vague and confusing?
Yeah, sorry. So you find often with genetic conditions there might be those that are very well defined and easily recognisable, but then there are also conditions which you could look at as sort of an umbrella of characteristics. So the same features or characteristics could be across a number of conditions depending on the stage of the child. So early on, there could be, say, 20 conditions that might all present very similarly in those first days or first few weeks. So depending on what's happening and what department in the hospital they're being looked after, there is usually a panel of conditions that can be tested for, but it really depends. And it's hard in those first days because they are looking at treating what's actually happening at the time and giving that baby quality of life, I guess, or easing those symptoms. And quite often the genetic testing might be slightly delayed. So one of the difficulties and one of the reasons why we push so hard for people to know about carrier screening and be pre-informed about their risks is that when you have a sick baby, there's what we call the diagnostic odyssey. So finding out exactly what's going on, getting a label or pinpointing the genetic condition that might be causing that can take time. And obviously there's a lot of suffering for both the child and the family while that's happening and while they're waiting to find a diagnosis. We advocate trying to get in front of it if at all possible.
Nigel, in your career, and Gina's and many who are in the laboratory, you at times receive genetic material, perhaps from a family overseas who've had a baby with a genetic condition and they are really desperate to have it identified, the mutation identified, so that they might even, would they even wait before they have another baby?
Oh. Yes. I keep going back to when the SMA gene was first identified, when the causative mutation was first identified, 95. I got this phone call from one of the SMA mums here in WA who said to me, we hear our genes being found, right? And it hadn't been published yet, but they were right. It was found in France. And basically, almost all of the couples who'd had a child with SMA were waiting until the gene was found before they tried to have any more kids. And so, yes, people put it off sometimes. But as far as getting samples from overseas, What we deal with are rare diseases. Tomorrow is Rare Disease Day. Each individual genetic disease can be extremely rare. So in order to find the gene, you need samples from different families, and sometimes they have to come from different countries around the world. So one of the first really severe disease genes that Gina found came from one family from Western Australia and one family from Turkey, in which she found variants in the same gene, and that was the first time that that gene had ever been hinted at as being a human disease gene. And then it turned out that there was a founder mutation in that gene in Japan, and that gene was responsible for a large proportion of these really severe paralyzing and neuromuscular disorders.
It's just needle in a haystack stuff, isn't it? Are there any more questions? Yes.
I was interested in why you talked about young people when a parent can be over 20 years, 20 to 40, for example.
I'm 70, Hilary. They're all young to me.
I think we are at time, but would you like one last question?
Well, I'm just curious, is there any genetic therapy for any of these conditions? So, I mean, the option that was given of termination, or IVF implants.
Yep.
But
so
is there any way of curing anything doing a modification of the genes?
So for the vast majority of genetic diseases, there is no treatment. There are some that do have treatment. Some of the treatments are pretty simple, as Sam said, what you were saying. Mostly the treatments that are coming online now are extraordinarily expensive. So the nusinersen Spinraza that Ruth talked about is $1 million a year for the first year and $330,000 a year every year after that. There's an alternative treatment for spinal muscular atrophy now, which involves injecting an adeno-associated virus that contains the gene basically into the ventricles of the brain. That's $3.5 million.
Okay, on that very somber note.
Can I give you one other somber note?
I'd really love that.
You talked about the length of time it takes things to move from a research result into actually being implemented. So a wise person from the East in the last month told me, you've got to remember, Nigel, that it was 15 years from the first trial of the bowel cancer screening until it got implemented into practice. So for Mackenzie's mission, that could mean that it will be 2039 before Mackenzie's mission carrier screening is actually implemented as a national screening program. Personally, I could not stand that, because every day, every week, every month, every year that passes, more Australian kids will have these awful conditions.
Identifiable conditions. Well, we need to, on that very somber note, wrap it up. Nigel, I do want to say thank you myself to you and your team on the work, and congratulations on the publication in the New England Journal of Medicine, which is quite an extraordinary achievement.
We're all on it.
I know you're all in it, and I believe the editorial was superb, that you got great commendations, so congratulations again.
So the editorial by Liedewij Henneman from the Netherlands said that the Mackenzie's mission results set the agenda worldwide for carrier screening for years into the future. Mm. All we have to do is persuade the politicians that they actually need to fund it.
Well done, and thank you.
So I'm just going to end on a slightly less somber note. the fact that there is a treatment for spinal muscular atrophy, which does change the life of those children, in contrast to all the wonderful things we've heard about screening, the fact that there is a treatment is the consequence of some fantastic biology. And that, we're talking about prevention predominantly here tonight, obviously, but there are some new therapies, and I know they're outrageously expensive, but the fact that the biology has led to new treatments is very exciting as well. We've had a wonderful panel tonight, steered wonderfully by you, Miriam. What a wonderful hour we've had. This is the cutting edge of science. We're doing it here at the Harry Perkins Institute. And I just want to thank our speakers, but before I do, I just want to remind everyone it is Rare Disease Day tomorrow, and any donations made will be met 1 for 1. So if you put $1 in, we'll match it with $1. So if you feel like donating, please do so tomorrow. Couldn't be a more apt time to have this lecture. And to Nigel, to Lucy, to Ruth, and Sam, what a wonderful night we've had. And Miriam, thank you for steering us so wonderfully well.